Hey, so I'm Dr. Barton Wood. I'm with Advanced Surgeons PC, working kind of out of Grandview, but also covering some other hospitals. Basically have a specialty in general surgery with a heavy interest in robotic surgery. Robotic hernia surgery is probably the main interest as far as teaching, research, and just my highest case volume.
Awesome. So most people have heard of laparoscopic hernia repair. How does robotic surgery differ from traditional surgery?
So the robotic surgery difference in laparoscopic, it's the next generation of laparoscopic surgery. The robotic platforms we use today, and there's really one major in the country that has approval, allows us surgeons to have better vision, better instruments, a lot more control inside the abdomen, as well as being able to do a lot more complex cases that just can't be done laparoscopically.
Gotcha. What situations do you prefer robotic over laparoscopic?
So in my practice, it's just about become 100% robotic practice. There's not any real laparoscopic procedures that I perform now without the aid of Da Vinci robot. I think where you get the most benefit from the robotic platform is in those more complex cases. So some of the more advanced hernias that traditionally you would only fix in big open procedures, now because of the advent of robotic hernia surgery, we're able to do those through small incisions, which increases your recovery time, less pain, less time off work, and now we're seeing even better outcomes from a recurrence standpoint, even compared to some of our bigger open procedures.
What are the advantages of robotic hernia repair for the patient in terms of recovery and pain and aftercare?
Yeah. So basically what we're seeing with robotic surgery, as we did with laparoscopy in the beginning, is that in this whole realm of something called minimally invasive surgery, that started with, once again, the laparoscopic procedures that we've all known. Our gallbladders, our appendixes, hysterectomies became minimally invasive. Now we even hear about minimally invasive spine surgery and minimally invasive neurosurgery in the brain. For the general surgeon, and especially the hernia surgeon, minimally invasive just means we're not making that big incision. So we're making these smaller incisions. The advantage of that is always less pain. So postoperative pain for a minimally invasive procedure is less almost across the board with that. We also see advantages of scarring and cosmetics. Having a big 12-inch scar versus 3 little half-inch scars, there's a big difference to patients and patient satisfaction. But on top of that, things that people may not be thinking about, infection rates are lower with laparoscopic surgery. We don't have a big incision to get infected. If the small incision gets infected, it's tiny. Things like hernias down the road. So the worst thing to do is to fix a hernia and cause a big hernia fixing the hernia. So incisions actually cause weakening of the tissue, which lead to hernia as well. When we do minimally invasive surgery, i.e. robotic surgery, we have less hernias down the road in post-op, as well as less bowel obstruction, scar tissue, chronic pain from all those things. So at the end of the day, my passion for years now has been to basically minimize my amount of open surgery. It's never going to go away. There are always things we're going to have to do through big incisions. But at least in the hernia world, we've been able to really take a large proportion of these open procedures, and now about 90% of my hernia work is done via robotic surgery.
When did you start robotic surgery?
So I started in 2000. I trained in 2011 on the robotic platform. I'd been in practice a little over 10 years then. At that point, it was really about the colorectal surgery part of it. The advances in the robotics as far as those type of cases was very interesting to me because the outcomes were looking really good. It was the same concept. Can we take some of these cases we're doing through big incisions and make them small incision surgeries? And that's where the robotic stuff came in. Around 2013-14 is where the hernia kind of journey, as I like to call it. I was not planning on being a hernia surgeon, and I do all types of surgeries, but hernia being a big part of my practice until basically the growth started with robotics. When I did my first robotic inguinal hernia surgery, it was one of the first in the Southeast. Probably not many in the country had done it, and that led to a lot of opportunities with teaching and training. I've since led about 180, 190 robotic hernia courses for surgeons all over the country, as well as we have surgeons come from all over the country just to come watch what we do, case obs at Grandview. So there are many times where we'll have physicians from as far as Seattle just to fly into Birmingham and watch us perform some robotic surgery. So that allowed it to even grow more. It got me in the lab. It allowed me to to basically transition to a little more of a teaching hospital at Grandview with the residents and do some research and other things that we've been able to do with hernia while keeping a very strong private practice clinical mindset. So we're not the university. You're not going to get caught in the big, kind of, don't want to mention any competitors, but you're not going to be a university, just a number. You're going to feel like you're at the small community hospital, but what you're getting is things that they may not be doing at these big university hospitals yet.
Oh, that was a great answer. I love that.
Mm-hmm.
I think you always want to feel like as a patient that you're important and you actually know your doctor and all those things.
Yeah. I think that's where, to me, this has really been a wonderful thing. I was at a little bit of a smaller community hospital just south of Birmingham at Shelby Baptist for first third of almost half of my practice now. That was a small time feel. That small town instincts of knowing the patients, knowing their families, operating on multiple family members in one family. And then you move a little bigger, and Birmingham's not, a huge metropolitan, but you start feeling maybe I'm losing some of that. I think, the advantages of being in a private practice like we are is we still feel like, our biggest marketing tool is, yes, how our outcomes are, what we do, robotics, being the head of the game when it comes to these great procedures. However, it's also our personalized care of the patient. We're not relying on basically a hospital to employ us. We are a private practice entity that's able to grow, continue to bring in our partners that we like, and grow this practice around certain specialties that we feel like are really going to be great for our community. We almost have our own niche in our practice. Mine is hernia, but we also do bariatric, but we have endocrine, we have, foregut and reflux. So we kind of cover this huge area of specialties. I'm just lucky that ours is in hernia for me, because that's kind of what I've built a career around.
Dr. Wood, what is a hernia exactly?
So a hernia is a tear in the main strong tissue called fascia. The way I explain it to most patients is you have a hole in your muscles. They should hold the stuff in. When the hole's there, something bulges out. So everybody comes in saying, I got this hernia, but sometimes it's bigger than others. The hernia itself is the same size. It's what's pushed through it. So I would tell my patients, it's, this is why it gets smaller when you lay down at night. Everything falls back into your belly. So most hernias come out through the abdominal wall, and this is the type of hernias we're talking about here. There are certain areas of weakness, the belly button or the umbilicus, and then the groin or the inguinal region. Those are natural hernias. You don't need surgery before they blow out on their own. The old patients call them ruptures because it kind of does rupture and stuff comes out. Other areas of hernia are more related to previous procedures. So you have what's called incisional hernias. Anywhere we've made that cut, there can be a weakness that then later on tears, and so now you have a hernia. So at the end of the day, a hernia is a hole in the tissue that allows stuff that's supposed to be inside of our abdomen come out under our skin.
Fascinating. Are there certain types of hernias or patient profiles that benefit more from robotic?
Yeah. I think that, if you look at the hernias that have really shown decreased chance of coming back, increased time or decreased time from work, decreased time of pain medicine, et cetera, it's almost across the board. All hernias now are showing with the data, and this has all been publicized now for several years, that the robotic surgery platform has been a huge benefit to patients with hernias. That a certain class of patient does better than others, I really don't think so, or a certain type of hernia better than others. I think where you see the most benefit are in our larger hernias that, once again, we're almost 100% done open. There are some now hernias that we're using almost a 12 by 12 inch piece of material to fix this hernia, and we're doing that through a 1 centimeter, half-inch incision. That wasn't even thought possible 20 years ago.
You're seeing a patient for the first time. What type of approach do you take with their hernia?
Yeah. So, a lot of it comes just with strictly physical exam. When we're seeing a patient, we have to actually lay hands on them to know how big the hernia is. We can't just look at a picture. There may be imaging. We may want to do CAT scans. So there are people who come to my office, and we have to send them from additional imaging. If you have a groin hernia, all I need to do is examine you, and I know that that's going to be what it is, and I don't change my treatment. So the first approach is kind of define the hernia, see the patient. As we always say to our medical students, do a good history and physical exam. That will lead to the next step. Then it's a based on experience type of situation. For me, I'm always looking for that minimally invasive robotic approach. And so when I look at the CAT scan, if it's a complex hernia or, larger hernia on exam, I'm always trying to figure out, is this possible to do? And if I feel like it's safer to do an open procedure, then I tell the patient, I know you want a robotic repair, but there's just some things we can't do yet. Hopefully one day we'll have more tools and better instruments, but at this point we need an open repair. But that's less than 10% of the patients. 90% of our patients, we actually offer the robotic first, discuss that with them. And then it's basically, going over in detail with that patient, what the recovery time is going to be, what their time off work is going to be, try to explain to them how the post-op course with pain, et cetera, is going to be so they can expect that this is, going to be, there's nothing wrong if you're having some pain or, here's the days you're going to have trouble, et cetera. And then we plan the approach and do the surgery. But at the end of the day, it's very patient-driven. Every hernia is a little different. And so we kind of have to look at it as how we're going to fix this hernia, what's the best approach and the safest.
Awesome. And are there any downsides or misconceptions about robotic surgery that patients should understand or bring up?
I definitely think patients have a big misunderstanding about robotic surgery. When we think about robots, we think about R2-D2 and C3PO, and you think, hey, Dr. Wood's going to drink coffee, and this robot's, in case they need him, Dr. Wood's around. And that's not the case. These are more robotic arms. I tell my patients, it looks to me almost like if you look at a assembly line for like a car or truck that putting things together, the arms kind of look like that. They move a lot more, but they're all controlled by me. The arms do not move without a surgeon controlling them. And so all it's really giving me is the ability to do, once again, a more complex procedure through small incisions. I think the other misconceptions, not just so about robotic hernia, but maybe hernia in general, is that mesh by definition is bad. We haven't really discussed this because it's coming up now, but almost 100% of my procedures are done with the use of mesh. That's not specific to robotics. That's for open procedures as well. And I do think there's a lot of misconceptions in patients, and I think a lot of those come from lawsuits that they've seen on TV. And what I try to tell my patients are, I'm going to do the best repair for you with the least amount of risk and the least amount of complications. I don't know any surgeons, myself included, that would do a procedure to increase your risk or your complication rate. And so if I'm recommending a mesh, which I usually do, it's because I know that's your best chance of having a good post-op phase and then long-term repair. I've had patients who really didn't want mesh, and one thing I've told them, I said, if your builder said you need this many 2x4s and you said, well, I only want half that many, and they still built your house, is it your fault the house fell down or the builder's? I think it's both. And so if somebody's asking me not to use mesh when I know structurally they need it for the strength, then I feel like it's just as much my fault as the patient who chose not to have it. So I think that's just an honest conversation that we always have with patients. And it's a misconception that all meshes are bad.
Is it a misconception that the mesh, does the mesh come out, or what is the purpose of the mesh?
So mesh is just a reinforcement of the repair. So the tissue's weak, it tears, especially in those primary hernia areas like the umbilicus. When we put stitches in it, it holds for a while, but then the stitches tear through. The stitches don't break, the tissue tears through the stitches. And so you end up with a bigger hernia after you fixed a hernia. And so the mesh is there to reinforce it. It's very much like putting a patch on your jeans, what your mom used to do when you were a kid. You had a hole in your jeans to get them out through the next semester. Your mom put a patch on it. She could have just sewn the hole shut, but if you bent your knee, guess what happens? The stitch breaks or the jeans tear. So they put a big patch on it, and you walked around with a patch on your jeans. That's similar to, it's a reinforcing material. The mesh that I traditionally use, and we have a bunch of different types, is made of the same exact thing that my sutures are made of. It's a surgical plaster that's been around for 50, 60 years. Heart surgeons use it to sew the microvascular vessels in your heart. So if you get a bypass, you have this material in your heart. So I don't feel like it's much of a stretch to use it as a mesh. And I think that's where the problem is. Doesn't mean that meshes can't have issues. It's usually an issue with the repair, the infection, the patient's ability to scar or not scar, and the mesh just happens to be part of that. So I tell patients those things would have happened anyway. It just happens that you have mesh in there now as well.
That totally makes sense. And I'm glad we talked about that because that is
it comes
I've
up a lot.
heard that myself. Yeah. So we talked about recovery being like a lot shorter. So I don't know if we need to dive deeper into that. Do you want to speak more about the recovery with robotic?
So I think, one of the biggest changes I've seen in my practice over a fair period of time is the ability to get people back to their normal activity, whether that's work or just functioning better at home, or kids having hernia surgery, getting back to sports. And so I think the thing that most interested me about the robotic surgery when I first started doing robotic hernia surgery is that I went from, 6 weeks to patients being able to function at a high level, getting back to the gym, doing construction work, et cetera, to cutting that to 4 and now to 2, and even to the point where some smaller hernias, my patients are already back in the gym doing cardio at 3 to 4 days. It depends on the hernia. Bigger hernias, I am closing tissue. It is going to cause pain. I don't want anybody to think these aren't painful procedures. But when I looked at a study of about 100 patients on pain for inguinal hernia, which is the groin hernia, for example, my average pain pill use was under 5 pills. My average return to work was 2 weeks, just because at that point I'd told people to take off 2 weeks. Now it's less than that. I tell people go to work when you feel like it, as long as you're not lifting. And I've actually gone to 2 weeks with no lifting over 20 pounds. After 2 weeks, I cut them loose on no restrictions at all. It doesn't mean they're 100% ready. They may still have some discomfort when they lift, but if you want to lift 200 pounds 2 weeks after a groin hernia surgery, there's no problem with it.
What should patients be prepared to ask their surgeon when considering robotic hernia repair?
Yeah, I think there's, we physicians have the benefit of knowing who we would use as our family, who, we would recommend as a surgeon, whether it's hernia surgeon or whatever, orthopedic surgeon, whatever. So we have the insight. We're kind of informed of who's good, who may not be that great, et cetera. So to me, when a patient's coming in, I think I would want to discuss with that physician their level of experience. And surgeons will be honest with you. I would ask, is this something you do on a regular basis? Is this something that you feel like is part of your specialty? Or is it just something hey, I showed up in your office, so I'll do it? I think, knowing how many the surgeon actually does per year or per month is a very important thing. The other things that I would like to, as a patient would want to know is, what are my complications rates? How do I fare when it comes to other surgeons? And I think most surgeons are going to be honest with you about that. And then just little things, I think, just even some patients want to know everything. Some patients literally come in, they want to know what kind of stitch I'm using, where they're going to be. Others put up their hand about halfway through the talk and say, Dr. Wood, I trust you. I do not need to know anything else. You just do what you need to do. So I think some of it is on the patient preference. But I do think that, actually asking a surgeon, is this something you're comfortable with, something that you're doing on a regular basis? Those are things that I would want to know from my surgeon.
If you were someone with a hernia, would you pursue robotic?
Oh, 100%. I think, I've said this many times in talks I give to other surgeons that are starting their robotic practices. The one thing I can say about my practice is the best thing I've ever done is train in robotic surgery. I trained in an era, it hadn't been that long, 13 years ago, 14 years ago, when essentially I was almost laughed at and said, why do you need this? Are you not a good surgeon? Those same people now are calling and saying, hey, can we come watch you operate? And so I've been very blessed to get into something early, have foresight and insight that this was going to be the next generation of physicians and surgeons. That being said, I can't think of any other type procedure that it benefits more than hernia, because it's such a difference between an open procedure and a robotic procedure. And so, yes, 100%. And if you look at data, I think it was in 2022 was the first year that more hernia surgeries were done robotically than any other way. So you look at a very early 10-year out from this starting, and in 10 years, it's taken over the majority. Laparoscopic hernia repair has been around for 20 years, and it never took over open surgery. Robotic did it in less than 10 and took over laparoscopic. So there's something to be said about how quickly we went from, hey, this isn't even a thing, to almost half, if not probably now 2/3 of hernia surgeries across the country are being done this way. So, when it really became apparent to me that this was a game changer in patient recovery, which once again, I got into surgery to fix people, not to cause pain. Sadly, with surgery, to fix people, we usually have to cause some pain, and that is a downside of being a surgeon. I had a young athlete, and young patients have very strong muscles, especially physically active kind of athletes. And so traditionally, we do surgery on them, they hurt more. You can imagine, very tight muscles, pulling them back together in a hernia situation versus somebody who's kind of floppy. So this was a young gentleman who was an all-state running back. He was in the middle of his senior year. He was looking at scholarship opportunities for a different sport and needed to get this painful hernia fixed before that sport started. He did not want to miss any football. His parents said, we need to get a scholarship in track, so we got to move on. We actually performed his hernia surgery on a Monday. He missed 2 football games. He was the starting running back 2 weeks later for a 7A football team in Alabama. That didn't happen with open surgery. There was no way. And when I tell people about it, they're like, oh, my patients don't hurt. And then when I tell them that story, they're like, well, wait a minute. That's a way different situation. My patients, I would have told them 6 weeks, which basically means the season's over. So that was the eye-opening that this is different. And since then, I pushed the envelope. It led to a lot of sports medicine referrals, but it also led to me letting people get back to their regular jobs sooner. Because if this 17-year-old can push through, keep working, stay in shape, why can't somebody who needs to get back to work? And so it was just an eye-opening experience, probably in my first 2 years of doing inguinal hernia robotic surgery, that I switched everything and said, okay, we can get these patients back like really, really fast.